Imagine your body is like a perfectly balanced scale.
Right.
On one side, you have this vital, carefully calibrated medication, and it's keeping a really serious neurological or, psychiatric condition in check.
Just doing its job day in and day out.
Exactly, maintaining your equilibrium so you can just live your life.
Right.
But then imagine dropping a seemingly unrelated, tiny daily pill onto the other side of that scale.
And the whole thing just tips.
Instantly, the entire system is thrown into complete unpredictable chaos.
It's a terrifying scenario, honestly.
Yeah.
But it's a real physiological reality for a lot of
Yeah.
people.
Yeah.
And I think it perfectly illustrates just how fragile that internal chemical balance actually is. Because, when we take a medication, we tend to think of it doing exactly one job.
Right, in a vacuum.
Yeah, in a total vacuum.
Yeah.
We forget that the human body is this interconnected ecosystem. A change in one corner, it ripples out to alter the very foundations of another.
The illusion of the isolated drug. So, to figure out how this actually happens, we are doing a deep dive today into a really incredibly specific but hugely consequential question.
Yes, we are.
Can oral estrogen, so the kind found in everyday birth control, secretly alter the efficacy or blood levels of anti-epileptic medications like lamotrigine?
It's a massive question.
It really is. And to answer this, we aren't just looking at, a single isolated study. We are crossing European pharmacovigilance reports with the actual master blueprints.
Summaries of product characteristics.
Yeah, the exact summaries of product characteristics for these drugs, along with clinical guidance from the Faculty of Sexual and Reproductive Health Care.
And, even if you listening have never taken this specific neurological medication or a hormone pill, you still need to hear this.
Definitely.
Because what we're really unpacking today is just this masterclass in how drugs compete for resources inside your organs. It'll totally change how you look at every single bottle in your medicine cabinet.
Okay, let's unpack this. Because to understand how a tiny hormone pill can cause such devastation, we first have to look at how the body normally processes a drug like lamotrigine,
Right.
and then how estrogen basically crashes that biological party.
Yeah, the party crasher.
So for context, lamotrigine is a pretty heavy-hitting vital medication. It's primarily an anti-epileptic drug used to stop seizures in their tracks.
Yes.
But it's also really widely prescribed as a mood stabilizer, right?
Mm.
Particularly for bipolar disorder, it acts as a shield to prevent severe depressive episodes.
And it's a medication where precision is just absolutely everything.
How so?
Well, for lamotrigine to work safely and effectively, it needs to be maintained at a very, very specific concentration in your bloodstream.
Okay.
If that concentration dips too low, the shield drops. The patient just loses their protection against seizures or psychiatric relapses.
Which is terrifying.
Oh, absolutely. But if it goes too high, the drug itself becomes toxic.
Right, so it's a tightrope. So how does the body actually manage those levels
Right.
day to day? We really have to look at pharmacokinetics for this.
Yes, pharmacokinetics.
Which is essentially just the study of how your body moves a drug around and eventually, gets rid of it.
Right.
Because when you swallow lamotrigine, it does its crucial work in the brain, but your body still recognizes it as a foreign substance. It wants it gone.
It does. It says, get this out of here.
Exactly. So the liver steps in to clear it out of the bloodstream, and it uses this chemical process called glucuronidation.
Yeah, glucuronidation, which is, it's a complex word for a relatively straightforward concept.
Right.
Basically, the liver attaches a sugar molecule to the lamotrigine.
Okay.
By tagging it with sugar, the lamotrigine becomes water-soluble, and that flags it for disposal so your body can excrete it through urine.
Making it easier to flush out.
Exactly. And that specific tagging process, it relies really heavily on a specialized liver enzyme.
Oh, the UGT1A4 enzyme?
That's the one, UGT1A4.
I like to think of that UGT1A4 enzyme as like a bouncer at a nightclub.
Okay, I like that.
Right. Like he's just kicking lamotrigine out the back door at a steady, manageable pace. The bouncer is doing his job. The club isn't too crowded. Everything is fine.
Until estrogen shows up.
Until estrogen shows up. Specifically, ethinyl estradiol, which is the synthetic estrogen found in most combined oral contraceptive pills.
Right.
So estrogen walks up to the club, hands the bouncer a megaphone and 6 hyperactive assistants, and just screams at them to clear the room.
Right.
Suddenly, the bouncer is throwing lamotrigine out way, way too fast.
And what's fascinating here is the sheer speed and scale of that clearance.
It's pretty wild.
It really is. We aren't talking about a minor, negligible dip in medication levels that the body can just adjust to.
No.
According to the data in the summaries of product characteristics, when a patient starts taking an estrogen-containing contraceptive, blood levels of lamotrigine can plummet by roughly 50%.
50%.
Yes. The observed range is actually between 41 and 64%.
Right.
And this drop, it doesn't take months to happen. It occurs within just one single week of starting the hormone pill.
50% in 1 week. I mean, that is a physiological cliff edge.
It is. And we really have to ground that in the real-world implications for the patient.
Yeah, let's talk about that.
Because a 50% sudden loss of lamotrigine means a sudden loss of seizure control for someone with epilepsy.
Oh, man.
Or a sudden severe relapse into a depressive episode for someone with bipolar disorder.
That's devastating.
Just imagine someone who has been perfectly stable for years. They have their life back, they're managing their condition, and then they start a standard birth control pill.
And days later.
Days later, their primary condition returns with devastating force.
It's just unthinkable. So if a patient absolutely needs both medications, right? Like they need the birth control and they need the lamotrigine.
Yeah.
The logistics of managing this just seem incredibly intense.
It is a massive clinical headache.
Because the standard medical advice in the sources dictates that doctors have to dramatically increase the lamotrigine dose to overcompensate.
Right.
They escalate it by, 50 to 100 milligrams a week? They sometimes end up literally doubling the patient's daily dose of the neurological drug.
Yes. Just to keep their blood levels stable while the estrogen is in their system.
So you basically have to flood the nightclub with more lamotrigine to compensate for the fact that the bouncer is throwing everyone out twice as fast.
Exactly. That is the accepted protocol to maintain the shield.
Okay, hang on though. Let's look at the classic 28-day birth control cycle.
Okay.
Because a standard pack of combined oral contraceptives is 21 days of active hormone pills, right?
Right.
Followed by 7 days of placebo pills, or a pill-free week, to trigger a withdrawal bleed.
Yes, the typical regimen.
So during that 1 week, the patient is taking 0 estrogen.
Correct.
So let me guess. If the estrogen vanishes, the bouncer's megaphone is gone. He goes back to normal speed. But the patient is still taking that massive, newly doubled dose of lamotrigine every single day.
Yes.
So what does this all mean? Does that mean the placebo week suddenly floods the patient's body with a toxic amount of the drug?
It absolutely does. The sources explicitly warn about this exact 21-day roller coaster.
Roller coaster is the right word for it.
During that pill-free week, because the liver has abruptly stopped clearing the drug so quickly, the lamotrigine levels in the patient's blood can literally double.
Oh my God.
The patient plunges straight into lamotrigine toxicity.
Walking around with double the maximum dose of a powerful neurological drug in your brain just sounds harrowing.
It is.
What does that toxicity actually feel like for the person experiencing it?
It is severe neurological distress. The clinical symptoms, they usually start with ataxia.
Okay, what's ataxia?
It's a profound loss of voluntary muscle coordination. So the person might start stumbling, they're unable to walk properly or balance. Yeah. It also causes nystagmus, which is this condition where the eyes involuntarily dart back and forth rapidly, making it impossible to focus.
That sounds terrifying.
There's severe dizziness, too. And ironically, dangerously high levels of an anti-epileptic drug can overload the brain and actually cause an increase in seizures.
Wait, really? The anti-seizure medication causes seizures?
Yes. If the levels get too high, it becomes completely counterproductive.
That is just wild. You take a scheduled break from your birth control for a few days, and suddenly you can't walk straight, your eyes are darting around the room, and you are having seizures because your own medication has essentially poisoned you.
Exactly. And this raises an important question about how we fundamentally prescribe these medications.
Me.
Because of this extreme fluctuation, the clinical guidance from the Faculty of Sexual and Reproductive Health Care suggests that continuous hormone regimens are sometimes considered the safest route.
Continuous meaning skipping the placebos.
Right. That means the patient skips the pill-free week entirely and just takes the active estrogen pills every single day.
Okay, I see.
It forces the liver to maintain that high-speed clearance constantly, and that prevents the toxic accumulation during the off week.
Right. It's a physiological high-wire act. You're forcing the liver to stay in overdrive forever just to avoid the crash.
Exactly.
But, we've been focusing entirely on estrogen.
Sure.
And combined oral contraceptives contain 2 hormones, right? Estrogen and a synthetic progesterone known as a progestin.
Yes.
So the next logical question is whether the progestin plays a role in this liver madness and whether the lamotrigine fights back against the contraceptive.
It is definitively a bidirectional street,
Really?
which just makes the clinical management even more complex. There's a pivotal study by Reimers et al. That looked into exactly this.
What did they find?
Well, they isolated the specific hormones to see who the real culprit was. And they confirmed that the ethinyl estradiol, the estrogen, is absolutely the primary driver supercharging the liver clearance.
Okay.
When patients took progestogen-only pills, which are commonly called the mini pill,
Right.
their lamotrigine levels generally stayed stable.
So if you're on lamotrigine, skipping the estrogen entirely and taking a progestin-only pill is generally the safer bet for keeping your mood or seizures stable?
Generally, yes. The progestin doesn't bulldoze the lamotrigine.
Okay.
However, the lamotrigine does attack the progestin.
Wait, really?
Yeah. The clinical data shows that lamotrigine actually reduces the blood levels of a specific progestin called levonorgestrel by about 19 to 20%.
So the mood stabilizer is actively undermining the birth control.
Yes.
A 20% drop sounds pretty significant. Does that mean the birth control just stops working and the patient is suddenly at risk of an unplanned pregnancy?
Well, clinical nuance here is really vital.
Okay.
A 20% reduction in levonorgestrel usually does not drop the hormone below the threshold required to prevent ovulation.
Oh, so you still don't ovulate.
Right. So, strictly speaking, the contraceptive efficacy is mostly maintained.
Okay, that's good.
However, that 20% drop can cause a loss of suppression in the hypothalamic pituitary ovarian axis.
Which means the communication loop between the brain and the ovaries starts to wake up.
Exactly. The body's internal hormonal signaling realizes the synthetic hormone levels have dipped.
Oh, I see.
It doesn't release an egg, but the fluctuation is enough to cause unexpected, unpredictable breakthrough bleeding. The patient experiences erratic bleeding throughout the month. It's a massive quality of life issue, and it's a clear physiological sign that the medications are actively warring with each other inside the body.
Here's where it gets really interesting, though.
Yeah.
Because digging deeper into your sources, it turns out you can't even make a blanket statement about the word progestin.
Oh, absolutely not.
The specific synthetic chemical used changes the biological math completely.
It does.
Like, the medical guidance notes that while most progestin-only pills don't mess with the liver bouncer,
Yeah.
there's a specific progestin called desogestrel,
Right, is desogestrel.
which actually might increase lamotrigine levels in the blood.
Yep. But then you look at a completely different progestin called drospirenone, and it might actually decrease them.
It's wild. Two synthetic hormones, both designed by scientists to do the exact same job of preventing pregnancy,
Right.
and they cause completely opposite reactions in how the liver metabolizes a neurological drug.
It just proves you can't just swap one generic pill for another at the pharmacy and assume your body will react the same way.
You really can't.
The exact molecular shape of the chemical you're putting in dictates the entire downstream effect.
Completely.
But this mathematical complexity doesn't just vanish when a woman stops needing birth control. The estrogen equation comes back with a vengeance later in life during menopause.
It does. Because women often turn to hormone replacement therapy, or HRT, to manage severe menopausal symptoms. Things like hot flashes, bone density loss, and mood swings.
Right.
And HRT relies heavily on adding estrogen back into the body. Okay, but a very common and very dangerous assumption here is that because HRT uses significantly lower doses of estrogen compared to oral contraceptives, the interaction with lamotrigine might disappear, right?
Yeah, or at least be too small to matter.
Logically, that makes sense. Like, a smaller megaphone for the liver bouncer should mean less of a reaction.
Clinically, though, that assumption completely falls apart.
Even with the lower dose.
Even with the lower dose, the summaries of product characteristics for major HRT drugs brands like Bijuv, Aless Solo, and Evrel,
Yeah.
they all explicitly carry warnings that the exact same interaction is expected.
Wow.
The estrogen in HRT still induces the glucuronidation of lamotrigine, clearing it out of the blood.
And the sources include this deeply sobering pharmacovigilance report that proves this isn't just a theoretical warning on a piece of paper.
Yes.
The Netherlands Pharmacovigilance Center, which is known as LARB, they detailed a real-world case of a woman who had been completely stable on lamotrigine for a long period of time, managing her bipolar depression. She was functioning, her life was balanced, and then in 2022, she started an HRT called Femostin to treat her menopausal symptoms.
And the timeline of what happened next is the critical part here.
Because 5 months later, she relapses into a severe depressive episode.
5 months.
Her doctors investigate and find that her lamotrigine blood levels had completely cratered.
Jets dropped.
The estrogen and the HRT had been silently, gradually draining her psychiatric medication from her blood for months.
It is a tragic example of medical silos.
Totally.
The doctor prescribing the HRT was likely focused entirely on treating the menopause, perhaps completely unaware of how that tiny dose of estrogen would fundamentally unravel the patient's psychiatric stability.
Wait, hang on though. I'm looking at these transdermal options mentioned in the sources.
Oh, okay.
Things like estrogen patches and gels, brands like Sandrina or Estradot.
Right.
Because when you swallow a pill, it goes down to your stomach, enters your portal vein, and takes a first pass right through the liver before it goes anywhere else in the body. Which is why the liver enzymes get so triggered.
Yeah.
But transdermal estrogen is absorbed right through the skin directly into your capillaries.
It is.
Doesn't that bypass the liver's first pass effect entirely? Like, shouldn't slapping on a patch avoid the liver bouncer problem altogether?
That is an excellent physiological deduction.
Sure.
I mean, theoretically, transdermal routes should have a much milder effect on those hepatic enzymes precisely because they avoid that massive, concentrated initial dump into the liver.
Right, because it enters the systemic circulation slowly.
Exactly. Slowly.
Yeah.
However, official medical guidance takes absolutely no chances when seizures and severe depression are on the line.
Okay.
If you read the blueprints for transdermal patches like Estradot, they still explicitly warned that co-administration can significantly decrease lamotrigine levels.
Ah, because even if the estrogen enters through the skin, the blood eventually circulates back to the liver anyway.
Right.
And the liver still reacts to the mere presence of the estrogen by ramping up clearance.
Exactly. The effect might be blunted compared to swallowing an oral tablet, but it is still clinically significant enough to cause a breakthrough seizure or mood episode.
Wow.
And if we connect this to the bigger picture, the management of a patient in this specific phase of life is just unbelievably delicate.
How so?
Because menopause itself fundamentally alters seizure thresholds.
Oh, right. Because estrogen generally excites the brain's neurons, while natural progesterone has a calming inhibitory effect.
Right.
And during perimenopause, a woman's natural hormones aren't just declining, they are wildly fluctuating.
Wildly.
This chaos frequently triggers something called catamenial epilepsy, which refers to seizures that are directly tied to the menstrual cycle and shifting hormones.
So you have a patient whose brain is already experiencing a much higher risk of seizures due to their own natural perimenopausal chaos.
Their natural shield is flickering.
Yes. Then you introduce HRT to soothe the menopausal symptoms, which simultaneously drops the blood level of the very drug they take to prevent those seizures.
That is just. So the underlying condition is flaring up just as the medical shield protecting the brain is being dissolved by the treatment for the flare-up.
Precisely. Which is why the clinical guidance heavily leans toward using transdermal estrogen over oral tablets for women with epilepsy, paired with extremely close, continuous blood monitoring.
Because even though it doesn't eliminate the interaction, it's better.
Exactly. The transdermal route is preferred not because it eliminates the interaction entirely, it doesn't, but because it provides a much steadier, continuous release of hormones.
It avoids the massive daily spikes and crashes of swallowing an oral pill.
Yes. Steadiness is the ultimate goal when managing the brain.
Wow. Stepping back from all the specific drugs and enzymes, the journey we just took through these sources is really profound.
It really is.
We explored this intense, invisible chemical tug-of-war happening inside the liver between estrogen and lamotrigine.
Yeah.
We mapped the extreme peril of the pill-free week, that 21-day roller coaster where a patient can suddenly become toxic just by pausing their birth control.
Which is still so crazy to think about.
Truly. We uncovered the bidirectional nature of these medications, where the mood stabilizer fights back and wakes up the brain-ovary connection. And we navigated the incredibly delicate balancing act required during menopause and HRT.
And I think the ultimate takeaway for you listening is why understanding these mechanisms actually matters.
Absolutely.
It proves beyond a shadow of a doubt why you can never look at a medication in isolation. Your body is a highly integrated, constantly communicating ecosystem.
Right.
A subtle change in one daily routine, like adding a tiny estrogen pill or slapping on a clear patch to help with hot flashes, it can stealthily, completely unravel the efficacy of a life-saving neurological treatment.
It totally changes how you conceptualize the treatments you rely on.
It does.
But, I want to leave you with a final lingering question to ponder as we wrap up this deep dive.
Okay, let's hear it.
Because we just spent all this time talking about how exogenous estrogen, so the synthetic kind created in labs and put into pills and patches.
Right, the external hormones introduced into the body.
Exactly. How that supercharges the liver to clear out lamotrigine. But a woman's natural endogenous estrogen levels fluctuate wildly on their own.
No.
They rise and fall during a normal 28-day menstrual cycle. They surge to massive, unprecedented levels during pregnancy.
It's true.
They swing unpredictably through the turbulent years of perimenopause. So, if a tiny synthetic pill can drop a crucial medication's effectiveness by 50%,
Wow.
could a patient's own naturally produced hormones be secretly altering their psychiatric or neurological medication levels every single month, even without them taking a single outside pill?
That is a profound question. We tend to treat the body's internal environment as a static, reliable baseline when we prescribe medications.
Right.
But it is a constantly shifting living landscape.
And if the scale is always moving on its own, balancing the weights on top of it becomes a lifetime's work.